Magda, have you had other presenters from Colombia in the previous weeks who presented a couple of weeks ago?
Only Zocali.
Okay, what did he do? Colorectal cancer?
About how about the Dr. Kali said? Que foi, Hélio? Eu não lembro mais do Zocali.
Rectal prolapse.
Rectal prolapse.
Okay.
Então, vamos começar. We start, HiIlary. Hoje nós vamos começar com um novo formato. Depois das duas apresentações, cada coordenador da residência vai ter um tempinho para a palavra. Hoje, infelizmente, o Dr. Paulo do Felício Roxo e a doutora Sinara do Ipseng não vão poder participar, então nós vamos ter a palavra do Guilherme aí logo depois das duas apresentações, tá? E vou passar a palavra para a Magda, para ela apresentar a residente e a Dr. HiIlary.
Como a Cântia falou, nós vamos começar, nós temos duas falas hoje, da doutora HiIlary e da doutora Gabriela, e nós vamos começar primeiro pela doutora Gabriela, que é residente de R1 da Coloproctologia do Hospital das Clínicas, da UFMG, e ela vai começar falando sobre a residência no Brasil, sobre a carreira de cirurgião no Brasil. Pode começar, Gabriela.
Vou compartilhar minha tela aqui. Boa noite, gente. Good evening, HiIlary.
Nice to meet you. Good evening. Thanks for having me, everyone.
Thank you.
Não encontrei nenhum compromisso entre hoje.
Okay?
Sim.
Just a minute. Oh, okay. So, good evening. My name is Gabriela. I'm from Belo Horizonte, Brazil. I'm a general surgeon. I'm now in the first year of colorectal surgery in Hospital das Clínicas, UFMG. First of all, I want to thank Dr. HiIlary for your presence here with us tonight and say that we are honored with her participation. So, I would like to talk about the colorectal surgeon training in Brazil. This is the current center in Brazil today. We have 257 medicine college with around 25,000 students per year. We have about 13,000 residents per year. In general numbers, we have today around 450,000 doctors in Brazil. Of those, 30,000 are general surgeons and around 2,000 are colorectal surgeons. We have a long journey of study and dedication. So first we were born and decided to be a doctor. And then we enter medical school straight out of high school after being approved in a test. The first 2 years comprise basic science and following 4 involves direct medical training. At the end of the 6 years, we do a final test about 5 areas: pediatric, gynecology and obstetrics, general surgery, medical clinic, and preventive care. We choose the specialty before applying to the residents, and the one with the best grades can pick the programs of their preference. In the residence program, we work 60 hours per week, normally way more than that, with the salary of $611. This not increase as we progress in our residence program, is the same salary for all years of residence. In Brazil, until 2018, the time of residence of general surgery was 2 years, but now the candidates have the options of 2 or 3 years. If they choose 2 years, they are obligated to do a specialization after. So residents in general surgery in Brazil focus on laparoscopic cholecystectomy, hernias, urgence and emergence, and oncological cases. We don't pass obligatorily in all the specialities, because normally we don't have all these areas in one hospital, and also we don't have time enough. After 2 or 3 years, the majority will choose the next specialization. For those who choose colorectal, we have 4 hospitals in Belo Horizonte. We have to do another test about general surgery containing about 45 to 50 questions. We compete for 7 positions. In colorectal residence, we spend 2 or 3 years. We learn open and laparoscopic surgery, colonoscopy and endoscopy at some hospitals, as well as classes, tumor boards, and journal clubs. After that, 10 years, a lot of tests, work hours, and study, we got it. We become a colorectal surgeon. And now we have to do another test in order to be certified by the Brazilian Colorectal Surgery Society. This is our journey to become colorectal surgeon. We can do this. Thank you. Okay.
All right, it sounds like our journeys are pretty similar, and I kind of did a little timeline as well. So I will go ahead.
Hilary,
Yeah. Yes.
wait a moment, please.
Okay.
Do you prefer me to call Dr. Simon, or can I call you Dr. Hilary?
You can just call me Hillary, Magda.
Okay, thank you. Oh, people say that every time you have a problem, you have a hidden opportunity. That's what happened to me. During the past year, amid a lot of work and in the middle of the pandemic, I had the opportunity to meet Dr. Hilary, who became a great friend. Dr. Hilary is Chief General Surgery Resident at Allegheny General Hospital in Pittsburgh, former colorectal surgery fellow at Columbia, New York Presbyterian Hospital, and she is brilliant, hardworking, organized, very generous and friendly person. She takes care of everyone as if we are a family. Besides that she is very intelligent. I'm sure she will give us incredible tips that will help everyone a lot of in understanding our organizing career abroad. Take it away, Dr. Hilary.
Thanks, Magda. You're going to make me cry.
Oh, no.
Let me go ahead and share my screen here. And let me see. Okay. Can everyone see that?
Yes.
Okay. This can be as informal as we want it to be. If I'm talking too fast, or I need to explain a particular thing, just shout out and say, Hillary, stop, explain this a little further. That's not a problem at all. I've spent a lot of time with Magda this year. We were both colorectal research fellows at Columbia, New York, and I think very highly of Magda. She's a wonderful, wonderful person and doctor, and she's the type of doctor I want to be when I grow up. Surgeon, doctor, person, human being, everything. So I'm really honored to talk with you all today. And I'm going to kind of start from the beginning, and I know that there may be some folks out there that are interested in maybe a career here in the United States. And so I kind of just went through the broad topics and what tests you have to take. But if you have any other specific questions, I have several international medical graduates at my residency, and I know their experience with becoming residents and physicians here in the United States, that I can answer questions if anyone has. So today I present the long road to surgeon status from a US perspective. Kind of like Gabby explained, we have to graduate high school, of course. High school for us is 4 years, to undergraduate school, which is college for us, 4 years typically to 6 years. I'm going to go through each bullet and each step here in depth in the coming slides. But then medical school, general surgery residency, and then you become a board certified general surgeon, and then you do fellowship if you want to be a specialty surgeon. So from an undergraduate standpoint, it's really everyone's individual choice. So personally, I was a biology major and I did chemistry as a minor, and then another minor that everybody who wants to go to medical school is essentially required to do is called pre-medicine. So that just means that, say if you wanted to be a history major, you're still going to get your baseline science classes that you need to be able to take the medical college admission test, which is called the MCAT, and contribute to a science grade point average, which is what medical schools particularly look at. While you're in college, and if you're interested in going to medical school, other things that you can do to kind of boost your application is, take advantage of volunteer opportunities, extracurricular activities. Myself and a lot of folks that I went to medical school with were college athletes. I think that particularly is important in the specialty of surgery, just kind of the team dynamics and working as a team and, being fit and, working long hours and kind of having that stamina to work 30 hours straight. And that's where you can kind of start building your application, way back in undergraduate/college. Of course, you need letters of recommendation. Medical schools, definitely read them. Some people think that they're just, another thing that you need to do, but they definitely are read. And then others, if you want to do more than your 4 years, there's no one particular track. Some people that I now am in residency also got their master's or a master's in public health or their PhD, which is anywhere from 6 to 8 years of college per se before they even make it to medical school. And along the way, I kind of put in some dollar signs because these tests can get really expensive. The MCAT here that you have to take to get into medical school is about $400 out of our pocket, which is the cheapest of all of the tests we take, and it's one of the hardest that we take. So after that, you apply to medical school and you go on interviews, and the medical school picks you based on your grade point average and that MCAT score and kind of how well-rounded of a person you are. So then you're accepted to medical school, and there are lots of medical schools. The number kind of fluctuates, but it's probably well over 300 here. And the tuition, depending on what state you live in, can range, this is kind of the average range of $30,000 to $60,000 per year that most of us take loans out for. So we have, close to $500,000 in debt when when we leave medical school, which is, you have to be pretty passionate and dedicated to a career in medicine to take on that type of, financial burden, if you will. So the first 2 years of medical school, it's typically academic where you're sitting in a classroom, you spend time in the cadaver lab, and then the following 2 years, the third year, you rotate each month through most of the specialties: medicine, family medicine, OBGYN, surgery. If you want to do kind of a specialty surgery, you can. And then somewhere in that third year, you take the United States Medical Licensing Exam, the USMLE Step 1. And that's anywhere, I think it's, at the last time I checked, is about $600. So that's fairly expensive too. And it kind of goes up from here. By the end of your third year, you should have a pretty good idea of what specialty you might be interested in. And so you really focus your fourth year and set up your fourth year as a sub-internship. So for instance, I did not rotate my fourth year through the hospital associated with my medical school. I applied to go visit other hospitals that I was interested in potentially doing a residency at, so I could go and do a tryout with them and figure out if I was a good fit for them and, you know, if they liked me. So that's the first part of your fourth year. And you do have some core rotations during the fourth year as well, at like medicine, psychiatry, OBGYN if you want to, again, just to get a little more OBGYN and surgery in. And then you take USMLE step 2. There is kind of an OSCE oral part of it, and then there's a written test. The written test now, I believe, is 1 to 2 days, depending on how you schedule it, and it's about 8 hours each day. So it's a really, it's broken up into pieces throughout the day, but it's pretty strenuous. And you know, I've spent probably the most time studying for step 2 in my life, and then just to kind of complete the USMLE exam, sometime during your intern year of residency, you have to complete the 3rd step to be an official like medical doctor in the United States. And total for all the USMLE step exams is about $3,000. Of note, throughout your 4th year, when you're applying to residencies, it's about $40 per application. So, you know, we're told apply to as many as possible because that increases your chances of, you know, being interviewed at a residency and therefore being entered in our match. And the match is essentially you rank your top programs, and each program that you interviewed at gives you a number. And then on match day, some big computer with a, you know, fancy algorithm does some matching, and you get an email saying you matched at this program. So it's not really your choice. You get to rank the programs that you liked top to bottom, but ultimately, if, you know, you ranked your top person, you know, number 1, and that program ranked you last, then you're probably not going to be going to that residency. And it's really nerve-wracking. And it's definitely a tough day. Match day is a tough day, especially if you don't match, but we won't go into the details of not matching. So you decide to become a general surgeon, and this is kind of how our general surgery residency is laid out. We have an intern year, just like all programs. And for the most part, we focus on the majority of patient care, just direct patient care. These are the residents that are, you know, on the floors, seeing the patients, answering the pages first, trying to sort out any issues before kind of bumping it up the line to the junior resident and or chief resident in regards to consults or emergencies on the floor or in an ICU. And then if there's time, depending on what service they're on, they can get into some basic general surgery cases too that are appropriate for their level. The junior residents, that's year 2 and 3. That's when you start getting into the OR a little bit more, and the kind of general cases that you'd normally see are appies, choles, maybe a right colectomy, hernias. On our kidney or on our transplant service, you know, be able to go into a kidney transplant. Typically, we don't send juniors to liver transplants. And then as a chief resident, which is the 4th and the 5th year, you're going to be doing some more advanced surgical cases. You know, your APRs, your LARs, and esophagectomy. We do cardiac surgery as a rotation. We do surgical oncology where we do Whipples, and the transplant service as well. You also have a pretty large administrative role as chief resident in regards to, you know, keeping track of your mortalities and morbidities and submitting them. We do a mortality and morbidity conference every week for an entire hour. So, you know, I'm not sure what you guys do in regards to M&Ms. Other programs just do it once a month, but at least at my program, we make that a weekly dedicated hour. And then sometimes, and depending on what fellowship or what specialty that you're interested in, and not everybody does a fellowship, there's still plenty of spaces in the United States for general surgeons to, work at more community hospitals to do your bread and butter surgeries, appies, choles, hernias. Even in our small community hospitals here, our general surgeons are, well versed in the robot. And so, you still have to, gain your skills during your general surgery residency if you want to do, robot cases as a general surgeon and don't plan on doing a further fellowship. But fellowship, again, is another expense. It's about $40 per application. And before COVID times, it was quite a bit to travel to each fellowship for each interview. And sometimes during fellowship interview time, it becomes quite a burden within our, residency because, having 2 or 3 chiefs out at an interview at once is kind of a lot of people gone and a lot of leaders gone at the same time. So it's just part of the process and we make do, but it's time away from operating and gaining more skills. And, I think it's something that we all could probably do a better job at. And maybe during COVID times, something good may come out of it where we can do more online and Zoom interviews. So to cut down on costs, but time will tell. And then I want to kind of further touch on research years. My general surgery residency program is 5 years. The University the University Medical Center in Pittsburgh here, their general surgery residency is 8 years because they force their residents to do 2 to 3 years of dedicated research. So, when they start their residency, it's a 100% commitment to, 2 to 3 years of research, where I chose a program that was 5 years long, initially thinking that I did not want to specialize and that I would be a general surgeon in a smaller community hospital. And, along the way, I fell in love with colorectal surgery and kind of decided to go out on my own and do a research year at Columbia with Magda this last year. And in regards to research, it really will help anyone kind of set you apart. And I would say any international medical graduate that's tried to match surgery or done a prelim internship year at my hospital has done research in the United States before trying to apply to a surgery residency here. It definitely helps set you apart. I think before I did a research year, I didn't completely understand the importance of coming up with a good research question and critically thinking through certain research questions in general. And I think hopefully I'm a better resident and a better surgeon because of my research year. But again, it's not required. Some programs do require it, and some residents choose to do a research year to, again, set themselves apart when it comes to applying to a fellowship in the future. Of note, salaries for residents vary state by state and city by city. Somebody that lives in New York City as a resident is going to be paid a whole lot more than I get paid here in Pittsburgh, just because it's much more expensive to live in New York City than here in Pittsburgh. So on average, salaries vary between $52,000 a year to $75,000 a year. And each year you progress, you get a pay raise. So that's a nice little incentive. In regards to testing, we take a yearly exam as general surgeons. It's called the ABSITE. It's every January. And each Tuesday, at least at my program, we spend 1 to 2 hours specifically studying for the ABSITE exam, whether it's through attending provided lectures or resident moderated lectures. But it is something that we do each week to be able to score well on the ABSITE, because again, that's another piece of a fellowship application. If you do well on your ABSITE, then you're more apt to be accepted to a fellowship. Other certificates that we have to hold and have at the end of our the completion of a general surgery residency is ACLS, so advanced cardiac life support, advanced trauma life support, FLS, which is your laparoscopic skills. We have to go to a testing center and test out for laparoscopic skills as well as endoscopic skills. And while we don't have a particular certificate for robotics yet, I know that SAGES is working on implementing kind of testing out on the robot, and I see that coming down the line in the future here in the US. Personally, at my program and most programs, folks leave with a certificate from Da Vinci, the robot company, and that is essentially a gold stamp when some hospital hires you, and you may be hired over somebody else by having that robot kind of stamp from Da Vinci. So we make sure we complete all of our Da Vinci models or modules online and on our Da Vinci trainer, as well as getting sign off from our attendings that we do train on the robot with. At the end of the 5 years, we take a written boards, and then we take an oral board. So you're only eligible to do the oral boards if you pass your written boards. And those tests cost about $1,500. Again, quite expensive for residents, but we manage. And then each state, depending on what state you want to practice in after you graduate, has its own application that you have to fill out with a fee. So this is kind of just a list of the most common fellowships that a general surgery resident can apply to. Cardiothoracic is 2 additional years. Some programs in the United States will kind of combine and do a 3+4, meaning your first 3 years you do mostly general surgery, and then your last 4 years is mostly cardiothoracic. It's a combined program, but in general, you complete a general surgery residency and then do an additional 2 years. Same thing with transplant hepatobiliary. Colorectal is just 1 additional year after your 5 years of training. Bariatric and MIS is an additional year. Endocrine is pretty rare. I think there's only like 12 fellowships in the entire United States, and that's an additional year. Breast surgery is an additional year. Surgical oncology, which some people feel like surgical oncology is very similar to colorectal, where I do know some surgical oncologists that will do colectomies pretty regularly. But for the most part, and from my perspective, a surgical oncologist is someone who focuses on, kind of crosses the line of hepatobiliary, focuses on Whipples, adrenalectomies, that type of kind of focus in their practice. Trauma, surgical critical care is an additional year. You have pediatric surgery, which is 2 additional years. I would say pediatrics is probably the most competitive fellowship to apply to, mostly because there are limited spots in the United States, but also it's always been competitive, at least since I've been a resident. There's also plastic surgery that's an additional 2 years, but you can also have that combined program if you apply early when you initially apply to medical school. And then there's vascular surgery, which is 1 to 2 years of additional training after general surgery, or there are some programs specifically dedicated to 5 years of vascular. At my hospital, we do have a vascular surgery residency that we do kind of intermix with, and we help their service out, and they kind of cross over and help general surgery services out sometimes too. So that's kind of the rundown of fellowship and opportunities and kind of the dedicated time based on what you'd be interested in. And then last but not least, after you complete all of that, you have to take some American Board of Specialty certifying exam, a written and also an oral, and then you apply for your job, interview for it, and then apply for your specialty medical license, just like you had if you were simply doing general surgery. And then you start your career. And so if I did the math right, it's about 15 to 18 years later after high school. So I'm still working on it. But it's been worth it so far, and I really love going to work every day. And, you know, I think the big, I don't know, I guess in general, at least here in the United States, and I've talked to Magda about this pretty extensively over the last year. And, you know, I'm actually appalled by how little surgeons make in Brazil. I think you guys deserve so much more. But here in the United States, I feel like I have to also put it into perspective. If I have like $500,000 in debt from medical school and all of the, you know, expenses that came with the tests I had to take and the travel expenses I had to, you know, kind of take on to go to all of the interviews, it's really kind of like we have to pay physicians more because we've made them in such debt early on. I still think that we probably get paid too much, but I think for the most part, we're all in it for the right reasons. We wouldn't go through 15 to 18 years of training if we weren't, I hope. And, you know, I still really encourage all of my medical students to consider surgery because surgery is fun. And I think that's what we need more of throughout the entire world. So thanks for everyone's attention. This is a few years back at my program, but all of the female residents, when I look like I look like a surgeon was a thing. And we kind of posed for this in one of the ORs one day, and it was kind of fun. Does anyone have any questions?
Thank you, Dr. HiIlary, for your wonderful talk.
Thanks, everyone. Again, I think if anyone is interested, again, in coming to the United States and practicing medicine and doing any research, it really is about who you know. You now know me and you know Magda, and we've spent some time at a research facility, and those folks know other people at other places. And it's really just like asking and sending emails and kind of taking a hold of your own education and future. And that's kind of what you have to do to get where you want to be. So I'm more than willing to help anybody get wherever they'd like to be. Magda has any of my information, and you know, I hope to see people at conferences someday when we're allowed to go to conferences again.
I would like to know if anyone would like to give an opinion in relation to what was presented by Dr. HiIlary, or ask to her a question. Dr. Mateus, Dr. Renato, Dr. Thais, Dr.
Hold on, HiIlary, could you stop your sharing, please, to see ourselves?
Podemos dar a palavra para o Guilherme. Guilherme está aí?
Estou aqui. Boa noite. Deixa eu abrir.
I feel bad. I should know more Portuguese at this point because I spent a year with Magda and Thais, another fellow from Brazil, and I just didn't pick it up as well as I thought. So props to all of you who have perfect English.
Our Portuguese is good.
So good evening, Dr. HiIlary and Gabriela. First, I would like to congratulate for the excellent class, but I would like to apologize because I'm a little out of practice in English.
It's okay, you sound perfect.
In Brazil, you say that we are a little husky. I don't know if this expression exists in USA. So I will speak in Portuguese. I hope you forgive me.
No, you speak in Portuguese and Magda will translate.
Ok, thanks. Bom, pessoal, boa noite. Fui pego um pouco de surpresa pela Cântica, pediu para eu falar um tempinho um pouco a mais, Mas eu gostaria, assim, é um assunto que tem me interessado nos últimos tempos, assim, depois que eu terminei a residência, é a questão do ensino em saúde. Não sei se todo mundo sabe, mas eu dou aula em 2 faculdades particulares de medicina, né? E esse ano a Renata me passou o bastão da coordenação da residência e da Santa Casa, acho que até mesmo por essa afinidade. E assim, aqui no Brasil está cada vez mais difícil, né? A gente tem acompanhado aí a questão da pandemia, o sofrimento que é do pessoal para formar, e a gente viu que essa questão do preço não é exclusividade nossa, né? Nos Estados Unidos também é bem caro essa formação, e no Brasil virou um comércio mesmo, né? A gente vê que as faculdades de medicina estão cada vez mais caras, e hoje eu dou aula na faculdade que é mais de R$ 9.000 a mensalidade, e eu fico falando assim, pensando quando que esses meninos vão ter um retorno, né, desse dinheiro investido. Então é uma caminhada longa, caminhada árdua, né? E no Brasil a gente, pelo menos eu acredito, né, do pouco que eu conheço, mas nos Estados Unidos o profissional médico ele ainda é muito valorizado, reconhecido e respeitado. Aqui no Brasil a gente está perdendo espaço para as outras áreas, o pessoal nem sempre respeita, então eu acho que a gente tem que realmente fazer uma boa formação, e isso até nos últimos anos a gente viu que mudou muito a questão dessa educação, né, do jeito que se ensina a medicina, do que se ensina a prática médica, as residências, porque antes a gente tinha muito essa questão do currículo baseado em estrutura, né, em processo, e hoje a gente fala mais de um currículo baseado em competência, né? A gente vai avaliar os resultados. Então, geralmente, quando a gente vai montar um currículo desse, a gente começa do que a gente espera que o residente consiga fazer, e daí que a gente vai montar o processo. E não, eu vou ensinar para ele isso, 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 e no final ele teria que saber fazer, né, tal atividade. Então, essa competência é a capacidade de mobilizar, de articular, colocar em prática os conhecimentos, habilidade, atitude, né? Então, a própria sociedade brasileira ela tem já, né, um currículo meio estruturado, a gente, né, sabe que não está próximo do ideal, mas que a gente tenta seguir. Então, tem que assistir tantas colonoscopias, tem que fazer tantas cirurgias laparoscópicas, e às vezes a gente acha que realmente o tempo, às vezes, é pouco, né? A gente sai, principalmente quando a gente sai da residência e sai da escola de medicina e entra na residência de cirurgia, quando você acaba de sair da residência de cirurgia geral, a gente sai bem cru, né? Não sabe muitas coisas, o que fazer. Então, quando a gente entra numa outra especialidade, acaba amadurecendo, mas a gente ainda sai, né, precisando de um algo a mais, e que só vem com o tempo, que é a questão da experiência, né? Então, lá na Santa Casa mesmo, a gente tem, né, trabalhado agora, a gente está mudando todos os currículos, né? Hoje em dia a gente fala muito na questão dos EPAs, né, os Entrustable Professional Activities, né, que seria a atividade profissional confiáveis, que é muito difundida de fora, principalmente no Canadá, né, os CAMEDs da vida, e a gente está fazendo isso, a gente pega o que o residente do primeiro ano ele precisa saber, então ele vai ter que fazer várias coisas, e para isso conseguir agregar um pouco na questão da formação. E não só aquela questão de que o professor fala, o aluno ouve, aceita, tem que digerir aquilo, para depois ter que repetir o que o professor está ali falando, né? A gente sabe que o aprendizado do adulto, o residente é um adulto, né? Às vezes o preceptor trata como uma criança, como um filho, né? Mas ele é um adulto. Então, o ensino de um adulto é diferente, né? A gente tem que levar que o preceptor não sabe tudo, o residente chega com a bagagem já, e a gente tem que entender aquela bagagem e aceitar. Então, a gente tem que conversar, né? Só mandar fazer e pronto. E nisso a gente tem questão do aprendizado, né? Que a gente tem aqueles 5 níveis de autonomia que a gente tem que seguir, que eu acho que deveria ser feito em todo lugar, porque a gente não precisa ficar pegando a mão do residente o tempo inteiro, né? Lógico, a gente tem que orientar. Então, no primeiro momento, ele tem que ficar vendo o que a gente está fazendo. Ele vai só acompanhar. No segundo momento, ele vai fazer com a gente do lado. No terceiro momento, ele vai fazer a gente próximo, não vai estar lá do lado sobre, né, a supervisão direta. A gente pode estar, por exemplo, numa sala ao lado, fazendo a colonoscopia, ele começando a fazer um exame, né, e por fim a gente está à distância, ele fazendo alguma coisa com mais autonomia, para no final ele estar ensinando também. E a gente às vezes pula algumas etapas, né? A gente pega na mão desse residente no início e depois já quer que ele saia fazendo. Então a gente precisa dar um pouco de autonomia também faz parte da formação desse residente. É lógico que não estou falando para deixar ele solto, né? No nosso serviço, pelo menos, o residente não faz nada sozinho, nem se for para estar ali próximo. Todo ambulatório tem preceptor, toda cirurgia tem preceptor, né? Eles não fazem nada sozinhos. Mas a gente tem que dar um pouco de autonomia, porque é um adulto que está em fase de treinamento e ele precisa disso. Então, se o tempo inteiro chama atenção, corrige, não é assim, é assim que você vai fazer, você não é o dono da razão. Essa pessoa pode ter uma formação, às vezes ficar meio receosa, ficar insegura, né? Então, assim, algumas considerações, né, que não sei se eu estou até fugindo do tema aí, né, Kátia, falando um pouco sobre a formação, né, como um todo, mas é um assunto que há pouco tempo vem me interessado, né? Então, inclusive, o meu mestrado eu fiz todo relacionado com coloproc, né, câncer coloretal, e agora o doutorado eu já estou fazendo nessa parte mais de ensino, né, de a saúde, né? Lá na Santa Casa a gente tem um grupo que a gente sempre discute essas questões, né? Já está mudando o currículo todo, né, da residência. Então, eu acho que é um assunto bem interessante e bem longo, né? Se vocês deixarem, eu vou ficar falando aqui o resto da noite. Então, queria que abrir a palavra para o resto do pessoal também. E agradeço a atenção sua aí e a oportunidade. Parabéns pela aula, Dr. HiIlary e Gabriela.
Excelente, Guilherme. É para isso mesmo que a gente quer esse espaço, para dar uma variada no assunto, para mostrar para a gente o ponto de vista de cada serviço. E aí, Magda, posso pegar o gancho do Guilherme e fazer uma pergunta para a HiIlary? Congratulations, HiIlary. Guilherme says that here in Brazil, we spend a lot of money to be a doctor. And then we don't have the return of the money. And he says that here you have this return. Do you think like this?
I do. I think, and I guess I didn't quite understand kind of the disparity between, you know, a U.S. Doctor's salary and, you know, salaries of doctors in other countries. And I don't know how you guys do it, honestly. Like, you know, and I think it goes back to truly, you know, picking this career from your heart to spend that much time towards your education and time throughout the day and the hours that you put in to really not get much in return. That's very, you know, brave of you. And Magda and I talk about bravery a lot. And I think, you know, I think very, very highly of all of you for, you know, taking on this career where I think you are underappreciated. It sounds like you're very underappreciated. Here in the US, I have to kind of reorient some of the residents and physicians sometimes when they say, oh, well, you know, we're not getting paid enough to do this, you know, blah, blah, blah. And I have to kind of remind them that we have it pretty good. We are, you know, reimbursed eventually as residents. Like I feel fine living off of my resident salary. Honestly, I could probably live off my resident salary for the rest of my life because I don't need to drive a fancy car or have a big fancy house or anything that, you know, several, you know, doctors that I know and learn from every day do take advantage of because of their salary. But again, I think probably this started and it's kind of a deeper rooted issue in regards to just how our healthcare system is set up in general. It's not a public health system. It's not a centralized health care system. It's, you know, public and private insurances, and it's very mixed. And, you know, it's a very delicate subject that, you know, is political in nature and, you know, a whole lecture on its own. I know, again, Magda and I talked about kind of the insurance and healthcare system in the US quite a bit with, you know, our time together over the last year and kind of contrasted and compared to, you know, the healthcare system in Brazil. And it's just very different. And I think salaries kind of boil down to how the healthcare system is, just the infrastructure of the healthcare system. And I agree that our healthcare system is kind of out of control in regards to money and reimbursement for procedures and, you know, who gets paid for what. It's just a lot. And it's going to take a very smart, motivated person to kind of break it down to its, bare pieces to really put it back together again. And I don't see that happening for a long time. So for now, we spend lots and lots of healthcare money on things that we probably shouldn't. And kind of in return for that, physicians still get paid, orthopedic surgeons on average get paid over $1 million a year in the United States, which is like ridiculous to me. But, I'm just a poor resident. So maybe I would feel differently if I was, a 60-year-old orthopedic surgeon who had been, putting in 90 hours a week for the last 30 years. But again, in my personal opinion, I think we just get paid way too much, but it's not even, at the physician level to take care of that. It really goes down to a healthcare system problem in general of how people are paid and who's reimbursed for what.
HiIlary,
Yes.
here in Brazil, being a woman and surgeon is not easy. How is the situation in the United States? It is a difficult task?
I think it is a difficult task. I don't think it's as difficult as probably it is in Brazil, just in also talking with Magda and getting to know her over the last year. I think it's most difficult in surgery. There are, for instance, just the other day, I had someone come in as a trauma, and because of COVID, we can't have family members come in to the hospital outside of visiting hours. Each patient gets one visitor their entire duration of the hospital stay. So this person came in as a trauma at 2 o'clock in the morning. His wife and son drove the 2 hours because he was transported by helicopter to our hospital. And they drove the 2 hours and they were out in the parking lot. And so, and the wife was kind of a mess. And I said, I will walk out to the parking lot and I will talk to, this family. And so I went and met the wife. She was elderly. She had to be transported in a wheelchair. So I was kind of pushing her back to her car. And, instead of assuming that maybe I was a physician, the son said something like, "Oh, Mom, you brought me a cute nurse," and so that is something that, I think we all as females probably come across every day, that you have to really be loud and proud when you walk into someone's room and really establish your role. I know Magda and I have talked about this in the past in regards to here in the US, usually we go by doctor and then our last name. So, typically I'm supposed to introduce myself as Dr. Simon, part of the surgery team taking care of you today. But I don't know, I actually prefer Dr. HiIlary. I just think it's a little more personable. And as long as, and I really don't care if my patients call me HiIlary or, leave out the doctor in general, but as long as they know I'm the doctor taking care of them and I'm not, the nurse or the respiratory therapist or, then personally that's okay with me. I have a lot of female mentors that are very serious about, walking into a room and establishing that, you are a physician. And I think that's important too. But I actually find that it's actually elderly women who are most apt to, not identify me as a doctor. And I think we'll get there. In regards to my program, like as a resident, do I think I'm treated differently because I'm a female? I would say that I think my bosses and teachers do a really good job of keeping it fair. There may be a few that are, definitely treat males different than females, as in, aren't as hard on them or don't expect as much or don't allow them to do as much in the operating room. But I think it takes people that I think I am to walk into the room and say, "Hey, Dr. McCormick, like I know that you let, Mike do this part of the procedure last week. and we're at the same level. And so I feel like I can do this part of the procedure this week. And I think that's bold, but it's kind of what has to be done in order to keep it equal and to make sure that everyone is treated fairly, whether good or bad. Obviously, you know, if I screw up or if I come unprepared, which is rare, I hope, then yeah, I shouldn't be allowed to participate in as much of the case. But if I'm coming just as prepared as my male counterpart, then I expect to be treated the same. And I think for the most part, my program does a good job of keeping it equal, but I know it's not that way for some of my friends in other places. Because again, surgery is a predominantly male concentrated specialty. And, you know, I see a lot of male names out there, so I don't want to step on any toes, but I think women are great physicians. Like we're really good at our job. You know, and we care. And if we want to be surgeons, we can. We can do it. And so I really, at least every year, I try to pick out a really talented female medical student that I think is interested in surgery, and essentially push mentorship on her. Just because we really, you know, I think that's really important. It's really important because diversity is important. It's important that I'm talking to you guys. It's important that, you know, now you can say, hey, you know, Hillary Simon in Pittsburgh, Pennsylvania, who's going to be a future colorectal surgeon, talked with us. And I know that I can always reach out to her if I have a question, or if I want to collaborate on a project, or if I want to learn more about the robot, or come to the US and spend more time on robots, or whatever you want to do, because that's what's really important. And so if we just kind of keep it fair and mix it up, that's how we grow as, you know, human beings and doctors and surgeons, in my opinion.
Thank you, Hillary.
Nice.
We had several residents with experience with outside Brazil. To start, Dr. Alain, can you tell us about your experience at Cleveland Clinic? And do you have any questions for Dr. Hillary?
Okay, thank you very much, Magda. Hello, Dr. Hillary. Nice to meet you.
Hey, Alan.
It was a great lecture. Thank you very much. Congratulations as well, Gabriela. Well, I had the opportunity to do an observership in Cleveland Clinic last year. I was in the colorectal department, and I could see many differences between what they practice and do there compared to what we currently doing here. I think the first and probably the thing that I noticed the most is that people in there, and I think that's kind of a US thing and also in Europe, is that almost everyone is very interested in research and in doing studies and getting mortalities and morbidities and also publishing papers. And that's something that I don't see here very often. So I think it's a great difference that I could see between there and here. Also, I saw that the American surgery in general, I think maybe most of the surgeons is kind of worried about getting sued and about lawyers. And I saw that this maybe even interfered somewhat in how the training of surgeons was done. And that's something that I'd like you, Dr. Hillary, to talk a little bit, if you can.
Yeah, I 100% agree with everything you said. In regards to the research, I think that because where the world is going is there's just so much to learn in general surgery residency. You know, 30 years ago, or, it was mostly open surgeries, right? And then laparoscopic surgery came on board, and now there's robotic training. And these are all extra pieces that, we have to spend time doing. And amount of general surgery training hasn't expanded. It's the same amount of time, but, and that's kind of forced people to do those extra years of fellowship. And again, because it's so competitive to then be a specialist and get into those fellowships, it's the research piece that's become important to set yourself apart. And I would say that I have mixed opinions about research. Obviously, I spent an entire dedicated year doing colorectal outcomes research at Columbia. And, you know, we definitely as a team came up with really great research questions. And then we came up with some really bad research questions. And, you know, I feel like some people can spend an entire year looking for a good question, and it takes a lot of time. So I would say, and you know, so many people sometimes focus on being first author on a paper or first author on a podium presentation or first author. And I think those are important. But I also think it's just important that if you want to set yourself apart with whatever you want to do, whether it be a fellowship or to come to the United States and do a residency to then be a specialist here, or just, you know, to increase your knowledge as, you know, a surgeon in Brazil, just the active practice of asking a research question and acting on it can tell a lot about a person. Because let me tell you, research is not for the faint of heart. It takes dedication and showing up every single day when you're not getting any great answers, and just keep coming back and trying again. And I will say, like, my research year was harder than most of my residency years for different reasons, but it was kind of grueling at times because it takes a lot to keep showing up when things aren't going right, or, you know, the numbers aren't working out, or, you know, maybe your mentor isn't getting your paper back to you with comments. You know, just those little things too that really kind of say a lot about you as a person that I think what people don't talk about, but I think fellowship program directors, folks that are looking to hire you for any position, if they see that you've worked on any piece of research, that says that you are a dedicated person that, you know, are interested in advancing medicine. And it really, I think it tells a lot about a person, which is to me number one. But again, I'm just, you know, this is just my opinion. And obviously a first author publication is excellent too. And I feel good about that too. But I don't feel like I need to push every paper that I wrote as a first author into publication if it was kind of a bad question, right? Because we don't want to be putting bad information out into journals. We want to put good, solid statistical analysis into journals that people can actually, you know, look at and say, this was a solid question, and this research group went through it in the appropriate manner and came up with a conclusion, or, you know, proved or disproved their hypothesis. And this might change my practice after reading this paper. Where so many papers that I feel like I read over the last year, which was eye-opening for me, I thought, so what? Like, what is this paper telling me? You know, yeah, this person was able to publish this paper and their name is first on the paper and they can put that on their resume. But if I'm interviewing them for a job and I go and read said article and I say, so like, what is this paper about? It didn't tell us anything new. It didn't advance medicine. It didn't really, you know, it wasn't a solid research question. And so you don't want to put things out there that aren't good either. You want to, and so I think there's a fine line of publishing papers and being a first author or even a third author on a really great paper than just, you know, saying, I did research for a year or 3 years. And, you know, my primary focus was colorectal, you know, outcomes or rectal cancer or whatever your passion is, that also says a lot. Because again, if you put out papers that weren't great, that can also hurt you. So, just to be really smart about your research too. And I think just the steps of going through how to do research is definitely a skill, at least I never had until, this past year. And it was a really important skill for me to have. And I think Magda feels the same way. We kind of went through the same thing together and learned together and, had reflected on what research is and what it's supposed to mean and why are we doing it, and all the questions that sometimes don't get talked about. I think when someone's taking a year or two to do research is like, just to make sure you know why you're doing it, and that if you are actually publishing data, that it's good and it represents the person that you are and your knowledge base. And, that's what I'll say about that. But yes, research ultimately is good. It makes you a better thinker. It makes you a better problem solver as a surgeon, I think, because of the reading you do and just like how you approach maybe problems. And I agree, we are really focused on morbidities and mortalities. And I do believe that it stems from the amount of lawsuits that go on in the United States. It's just, again, how our system is set up. If someone messes up, people will go after them. And it's very sad. And unfortunately, that is the type of people we are here at times. And, but I think it's really important. And what I've learned in my training, and I've also talked to Magda about this as well, is it's really important to make that connection with your patient. So because people make mistakes, we're all humans, right? And for some reason in the United States, we have to be perfect. Somebody said, doctors have to be perfect. They're not allowed to make mistakes. And if they make mistakes, then we will ruin their careers, we will take their money, and it turns into a really big problem. And so I would say my focus as a surgeon in training is to really go and be a human being with my patients when I meet them for the first time. Introduce yourself, sit down next to them. Don't stand, in the door and talk to them from the door like, they all have COVID, which unfortunately has made things difficult from that perspective. But it's amazing how someone who makes a mistake, a surgeon who makes a mistake, who's a nice person, who spent the time to talk with their patient and their family and say, hey, I screwed up. Those are the people that will not get sued. The people who typically get sued when they screw up are the people who are not, human with their patients. Their patients are a number, which, not all doctors are created equally. I think that can be said across the board, and we all can just hope to be the doctors that are good. But the folks that really don't spend the time with their patients are not going to make their patients feel good. And if someone doesn't feel good, then those are the people that will act out and are the ones who will, file for the lawsuit. So again, I think it's a problem, and I think it can be avoided most of the time if you take the appropriate initial steps. But I agree, it does affect resident training. There are certain times where, even an attending of mine that's, 50 years old, so trained 20 years prior to me, said, back in my day, I used to do this entire case start to finish, and my attending would sit in the corner and watch. And now I have to be scrubbed in and do 50% or more of the case because of, just the nature of potentially being sued. And it's unfortunate. And I do think that resident autonomy and being allowed to really gain the skills that we need to be great surgeons are sometimes hindered because of that thought in the back of everyone's mind of like, if a resident were to really screw up, then, you know, I could lose my job and my career forever. But again, I think it's complicated and definitely not straightforward, and really puts a lot of pressure on residents and attendings, because, you know, the attendings are dedicated to educating residents, and, you know, how frustrating it must be to not really allow residents to do as much as maybe they had been allowed to even 10 years ago because of, again, kind of the cultural and political status of the United States at this time. So again, I think the best thing that residents can do all the time is prepare for your cases, practice, 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 and show up prepared. Because if you show up prepared and, you know, say, I can do this and actually do it, then you're going to be allowed to do more each progressive case with that particular attending. And that's the way we're going to get trained, you know.
Other two quick things that I noticed, and that is linked to what you just said, is that at the observership, I saw that most of the time, almost everyone from the doctors to everyone in the team was always like seeking to be better and to do a better thing. So it's like when you are in clinics or in the wards or the OR, they always say, how can we improve this? How can we get this to work better? What's your feedback? What input do you have for us to like work better as a team? And that's something that sometimes I see in here, but not always. So that's something positive that I think we can like learn from the US. And the other thing is that the patients, like you said, they do not accept mistakes. They want the doctor to be perfect. And I saw that even in clinics, before the surgery, the doctor most of the times had to explain in details to the patient exactly what is intended to do and what's going to happen. And sometimes I saw a patient asking like the stapler, how many rows did the stapler have? So how like things that are very specific, and the patients in Brazil doesn't often like even know that exists. So it's something that I noticed.
I agree. That makes it really difficult, where at some point you have to say, I spent 15 years, like we've discussed today, going through this training to become an expert in my field. And, you know, for patients to still show up to clinic and then dictate their own care and kind of disregard the expertise that they've sought out for whatever operation they want is difficult. And unfortunately, because of the fear of being sued, we sometimes have to allow patients to decide the care they get, which, you know, I think in general, certain doctors are better than others of kind of taking the conversation away from the patient and bringing it back to, but this is what I would recommend because I am the expert. And saying it in a way that, you know, really resonates with the patient rather than putting up a barrier of, you know, oh, well, this doctor doesn't care about me or they're not listening to me, which again are all barriers to getting to the operating room, because you're absolutely correct. We see that all the time. And, you know, some of my bosses will be better at saying, you know, let's do this because, you know, they'll only accept this procedure because they said they would never want an ostomy. But like we all know that we have to put on the consent form possible ostomy in certain cases. And, you know, I've seen major standard of care decisions change in the operating room because of a patient flat out refusing to even listen to the possibility of having an ostomy that could be reversed in the future. And it just isn't right. You're 100%. It's not right. And it's really difficult. And I don't know if I have the right answer of how we change that other than, you know, going back to residents and female residents showing up and saying, I'm the physician taking care of you. this is my medical expertise, this is what I suggest, and this is what I think we should do because this is what's best for you. And, you know, and hope that your deliverance in that really sits well with the patient and things go the way they're supposed to go. But again, very difficult. But I like your positive that you took. I agree, teamwork is great. Every week as kind of a leader of my resident team, we kind of sit in a circle when we have some time and we say, hey, what did we do well this week? What can we do better next week? You know, 360 review, they can say what they need me to do better as a chief and a leader, like, hey, Hillary, you didn't communicate to us that you wanted us to do this, this, and this in the morning. We need you to do this better next week. And I say, okay, let's do it better next week. And that really does make a difference in regards to making care better and looking out for the patients ultimately. And that's what the most important thing is.
Thank you very much.
Our time is running out, but I think Dr. Renaro and Dr. Mateus have a question. Feel free, please.
Hillary, good evening.
Good
Thank
evening.
you for the lecture and for clarifying to us some of the long road that you took to get where you are today. So what I want to ask you as a young colorectal surgeon in Brazil is what of the road that is just beginning that you're going to begin your walk soon as a certified colorectal surgeon in the US. So what are the troubles that you're going to face, the difficulties that I think that every resident, even if they really like the resident program, they want it to end someday and become fully independent. So what is it like to get into that part of the program and what comes next? That is what I wanted to ask of you.
So I think it's always a relief when you take that next step or you're allowed to be advanced that next step of, you know, the ladder of like my first PowerPoint slide. But it's always a next step, right? But I think that's both a little stressful, but definitely motivating. And what we kind of all secretly love as surgeons, right? The fact that there's always that probably next step of something that we can learn and take the next step and be an expert in minimally invasive or an expert in rectal surgery, or there's always that next step and training opportunity. And, you know, I don't think we all would ever be at this position in our lives if we didn't love that ability that to know that we have that next step option. So I right now am nervous because, you know, last year there were, I think, 149 spots for colorectal fellowship. 149 applicants rather. So 149 people wanted to do colorectal fellowship and there are only 50 positions. So, you know, almost 100 people did not match. And so, you know, then you're left to say, what again, going back to that reflection, what did I do wrong? What can I do better? What test can I take again and, you know, potentially score better at? Do I have to do more research? Do I need better letters of recommendation? Do I need to go back to, you know, the attendings that wrote letters for me and say, you need to write me stronger letters. What can I do to allow you to, you know, create a letter that better reflects who I am and that I deserve to be accepted into a colorectal fellowship? I'm mostly nervous about this because a chief last year who I felt was a spectacular candidate scored, 90th percentile or greater on the ABSCITE every year, did a little research, held academic chief position, like did all of the things right, and she didn't match. And so I have to say, wow, Ashley didn't match. There's a potential that I couldn't match. And that's something you have to think of, and you have to have a backup plan. A lot of the time, folks who do not match into fellowship, there are non-accredited fellowships or opportunities at Cleveland Clinic, at other bigger centers that will take fellows, but for minimally invasive surgery or potentially colorectal. But at the end of that year, you will not get a board certified certificate. It's just an extra year. And some people will have to do that extra year to then reapply to the fellowship, because you can only be a colorectal surgeon if you complete a certified colorectal fellowship that then makes you eligible to take the specialty boards, and then so on and so forth. So I think you just have to always be better. And I think that's very stressful, and some people don't handle the stress very well. There are better days than others for me, but just knowing that that's the expectation, is that you just have to do your best. But I think there is a lot, again, to be said about being a good person and someone who cares, because I would much rather have someone who genuinely cares and is willing to sit down and talk through any, reservation I may have about having a surgery, than spitting out facts and saying, well, we're doing this surgery, it's scheduled for Tuesday, see you then, goodbye. There are definitely certain personalities that, I would pick over others. And hopefully that's something that may set me apart in the future. I really love my patients more than anything. And, they deserve the best, in my opinion. And, but I don't know, every day I try to get better. I read, I practice, I get to the OR as much as possible. I help my teammates out. We do 360 review of how we all can be better every week. We ask our attendings for feedback. We actually have an app on our phone. It's called Simple, SIMPL. And you can actually just send your attending like a little message through this app and say, hey, can you give me feedback on that lap chole we did, this morning? And they have up to, a couple of days to fill out this like brief feedback thing on the application on their phone. And that's kind of worked well too. It's been a little learning curve getting our attendings kind of on board with having the apps on their phone, and looking at the app to make sure that they're seeing when someone's asking for feedback. Honestly, if I want feedback, I just ask the attending for feedback. Some people are more intimidated by attendings, and they feel like that app kind of gives a good buffer so that, people can be genuine in their feedback. But I digress. I think we always have to be willing and able to do something different if plan A doesn't work out. And most of the time, if plan A doesn't work out, it was probably meant to be that way. At least that's what I've kind of found in kind of my journey in getting here, that if you think you're supposed to be doing something and it doesn't happen for you, and it forces you in another direction, you're probably meant to be in that other direction, and to just go with it. So we'll see. And I truly believe that my passion is colorectal surgery, and that's my plan.
Great.
Dr.
Yes, if anybody, I'm going to try to answer the questions in the chat here, but if anybody has any other further questions, Magda has my email address. She has my cell phone number that she and I kind of, go back and forth in the WhatsApp. So I have no problem chatting with anyone ever. even if you just want to come to the United States to visit and hang out in Pittsburgh, I have a 3-bedroom house that you're more than welcome at, for real. So Magda knows that too. I'm always inviting everybody. We love to host.
Dr. Renato, you have a question or not?
Yes, I have a quick question. Boa noite a todos. Well, thank you for a wonderful class, HiIlary, and I would also like to thank you for taking good care of Magda in the past year. She's a role model for a lot of us, not only as a surgeon, as a person, and every single aspect of it.
She's the best.
We know, and we're happy she came back.
Yeah. Yes.
So it's more like a practical question. How does it happen for you to take up responsibilities and operative time in your surgery residency? Do you have to, obviously you have to be prepared for your case, as you said, but do you have to have a certain number of procedures that you have to participate in that, or cadaver lab? How does it happen?
Yeah, so there's no mandatory cadaver lab. We do pig labs sometimes if a like Medtronics or some industry wants to sponsor a pig lab for us to try out a new laparoscopic instrument or something like that. But for the most part, there's no like ACGME governing body of residencies requirement to do a certain number of hours on a cadaver. We do all of that in medical school, but we do have to have 850 cases by the end of our 5 years, which is doable. At least at my program, we all usually end up with 1,200 or more cases in the 5 years. So we're well over the minimum requirement of cases. Now, that doesn't necessarily mean that we're experts in those cases, right? Because going back to that autonomy part and what we're allowed to do in each case, most of us up until our 5th year, we don't do, unless it's like an appy or a chole or maybe a pretty straightforward hernia, we're not doing the entire case start to finish because of regulations and rules and everything, and not because we don't want to. I think residents just have a tendency to always want the ability to be allowed to do more. But as a 5th year chief, that's when you kind of are allowed to have more free reign, start the case by yourself, and then the attending kind of shows up in a little while. But again, I think that's also based on who your boss is that day. There are definitely more strict bosses that want to be there and watch every move you make. And then there are other attendings who, are seasoned attendings, are very talented, and I think are of the mindset that there's nothing that a resident could screw up that they could not fix. So that's always kind of nice to work with an attending of that mindset too. Not that, anyone wants to screw up, but usually those are the people who allow you to do more and, go as far as you can before asking for help. But again, I think it's about taking control of your own education. I think personality plays a part. If you show up and you're prepared, everyone has their preferred textbook that they like. There's no like one textbook that, you have to read. I do a lot of reading out of Cameron's. I have, techniques books, and, we have access to all of them. And some of them are better than others in regards to certain procedures. But again, if you show up prepared, you're confident in your skills, even saying that you've spent such and such amount of hours on the trainer last week, the robotic trainer, the laparoscopic trainer, and that, you practiced your endo stitch, and that you want to throw every endo stitch on the Roux-en-Y gastric bypass this week, And if you say it and, you know, you kind of establish that kindly and professionally at the beginning of the case with your attending, you're apt to do more. But again, it takes that kind of taking control of your own education to really get the most out of it. So if you're someone, or, you know, there are several residents that I work that are, you know, colleagues of mine that just, you know, kind of hang back and wait to be allowed to do things and be offered the chance to, you know, perform that next step of the case, that where I'm more a little bit pushy and I say, hey, you know, I want to do this because last week I got this far in the case. So this week my goal is to get, you know, to taking down the entire splenic flexure or whatever it may be. So I think it's just individual dependence. And, you know, again, you just have to push for what you want to be good at. And if you are working with the people that you're supposed to be working with, they typically allow, at least in my experience, allow you to really grow as a resident if you ask and are prepared.
Our time is running out.
Let me say just one thing first.
Okay.
Dr. HiIlary, we have to thank you very much. And now I know how Magda likes you so much. You are the kind of person that we stay talking about a lot of things, a lot of hours. Thank you very much.
Well, thanks for having me. You know, I know a lot about all of you as well. Magda thinks very highly of all of you. And, you know, it's always, oh, you should hear about my friend Kelly. You should hear about my friend so-and-so and my resident so-and-so. Look at this picture my resident sent. I'm like, oh my gosh, you are the attending that I also want to work with, Magda. So, you know, I am so glad to have met Magda, and she is my friend and mentor, and, you know, someone I look up to very, very, very much. And I love her to death. And hopefully sometime when, you know, COVID hopefully goes away, I will make my way to Brazil, because I would love to come and visit, but I need to work on my Portuguese.
No, your Portuguese is perfect. Thank you, HiIlary, for accepting our invitation. I know how busy you are. I know. And you spend your time with us. Thank you. Thank you.
It's been a pleasure.
And for your wonderful talk. You know, I love you so much. Thank you.
Love you too. And guys, again, reach out to Magda if you have any other questions. If I don't answer you like today or tomorrow, it's just because I'm just, you know, working a million hours, but I will get back to you. No problem. Okay.
Okay.
All right.
Thank you. Thank you.
Thank you so much for the presentation.
See you guys. I'm gonna write in the chat.
Just say goodbye.
Bye.
Goodbye, everyone. Thank you.
Thank you.